Good afternoon, good morning, depending on where you are in the world today. Thank you for taking the time out of your day to join our DM Connect. My name is Tracy McFarland. I'm the Director of Professional Education here at Dental Monitoring. A little housekeeping for us today. As we're going through our webinar, please make sure as questions come to you, please put them down in the chat feature or the question and answer feature down at the bottom part of the screen. At the end of today's webinar, as we're going through question and answer, we will also have a survey. If you guys could take a few seconds to take the survey for us, it will help to ensure that we're bringing you the right training information that you guys are needing for 2024. With that, today we want to welcome you to our webinar, and Dr. Barry Benton, who is actually one of the youngest diplomats of the American Board of Orthodontists, is joining us. Dr. Barry is the owner of Designer Smiles by Benton in Oxford, Alabama. So for you guys who don't know where Oxford, Alabama is, he is in a suburb between Birmingham and Atlanta. Almost, I would think, right in the middle, but a few miles may put us off a little bit. Dr. Barry owns 2 locations where he does practice in tandem with his dad, Dr. Benton, and they have 27 team members and a dog named Teddy. You're going to learn a little bit more about Teddy through the presentation today. Dr. Barry and his team began using dental monitoring in 2020, and he and his team have taken key steps in defining dynamic scheduling for them and why it is important. Dr. Barry, take it away and teach us a little bit about dynamic scheduling.
Awesome. Thank you so much, Tracy. We are lucky today. The sun is shining. The cows are all pointed in the same direction. So the internet is holding strong here in Alabama. Let's hope that for the next hour, they stay heading in the right direction. I'm gonna go ahead and share my screen with you guys. Please let me know if it doesn't come up the way that it should. And there we go. And I want to take a moment to talk to you guys today about dynamic scheduling. It's a little bit of a buzzword in our community. It's kind of hard to define. People are using it different ways. And when I was first researching it, I was in that same boat. I was trying to figure out, okay, what does this actually mean? What's going on? Can it help me? And I'll go through a little bit of my practice details, the situation that I was in that really helped push me over the edge into it, and then share some of the pitfalls that I had, a roadmap to help you guys avoid those pitfalls, and kind of ultimately end up where I am today as far as how I'm practicing and interacting with our patients here in Alabama. So first, this is our main location here in Oxford, and this is the practice that my dad started in 1985. I was fortunate enough to be able to come back and join him in 2016 after I finished my school, and I've loved every minute of working alongside my dad. It's been honestly one of the best things for us, and I will not let him retire. I refuse to, so I'm gonna make him hang on as long as possible. Like Tracy mentioned, we do have 2 locations. We opened our second location about 30 minutes up the road in the town of Pell City. We did that in June of 2020, which was a whole nother story in and of itself, trying to launch a de novo satellite in the midst of COVID. Like we mentioned before, it's just me and my dad. That hasn't always been the case, but more to come on those details. We do have 27 team members, so we've grown a lot over the years, and this is the biggest team that we've had, but also one of the best teams that we've had. So we're fortunate and blessed to have them alongside of us. Tracy mentioned Teddy. He is a certified therapy dog that helps us at both locations. He has completely changed the dynamic of our practice and the way patients feel coming in. There's just an excitement, but at the same time, just a calmness in the practice because of him. And, you know, at the end of this list, we'll throw in a partridge and a pear tree because it is the festive season. This is the most up-to-date team picture. Again, we've added a few members since this photo was taken. So it's not complete. So if you're counting heads, you won't get to 27, but rest assured that's where we are there. And you can see Teddy right there in the middle, just loving every minute of it. So why DM? Why did I choose to even go into the remote monitoring space? What was going on? What was my decision matrix, decision tree like when I was making those decisions? Well, I made the decision, during COVID. We were shut down. We needed some way to monitor and keep in touch with our existing patients, as well as a way to continue to acquire new patients, because none of us knew how long we were going to be shut down, what the landscape and the future looked like. So when I started looking at all the options in the marketplace, DM was and is the only one that allows the level of automation that I required and that my team required. So there are other options out there, but there's a lot of manual work, manual review that goes into being able to deploy those tools. And DM partnered or paired a stellar remote monitoring process with some automation that allowed it to be a force multiplier in my practice. So what we'll talk about today, first, we're going to try and wrap our minds around what dynamic scheduling actually is, how to define it, what are the definitions of it, and then we'll go through some of the benefits. So why you should consider deploying a similar model in your practice. And then finally, we'll end with the workflow, the roadmap on how to implement it. I'll share a couple different strategies and then ultimately end with the way that I did it in my practice. Here we got Teddy again. So as we kind of narrow in on what dynamic scheduling is and what it is not, there are several, like I said, different models, different definitions floating out there. So just like I asked you guys, I wanted to ask some of my other colleagues as well and kind of see what they were saying, like how did they define dynamic scheduling? These are all doctors that in their own words, say that they're using dynamic scheduling in their practice. So that's why I selected these docs for this question. And you'll see that there's a variety of answers that I get back, which shows just the breadth of what dynamic scheduling could entail for your practice. So when talking about their aligner patients, they pretty consistently wanted to give all their aligners. They're only bringing them into the office for an IPR, an add attachment, or at the end of a group of aligners. Some say, no appointments scheduled in the office. So everything is done, through the dental monitoring app or the patient's calling in when they get to certain points. One office, they give 12 aligners. And then if the patient is progressing well and being compliant, they'll give the rest. If not, it gives them a chance to kind of recapture the patient and see what's going on. So again, this is all very different. Some are giving all the aligners and scheduling, some are not scheduling at all, some are given a group of the aligners, and then if everything's going well, not scheduling them. So again, there's a lot of variety in how you can deploy this. Shifting gears to brackets, one of my good friends used the term dynamic rescheduling, which I think is a great way to think about it. And what she does is she will use the information, the data that she has about how she treats. She'll appoint the patient in the office for a time that she thinks is the right time for the wires to go passive. And then she's monitoring. And when they get to a point where they're ready for the next wire change, she'll look and reschedule that appointment either up or back into the future, depending on how the patient is progressing. So they leave with an appointment, but that appointment is really just a placeholder, and the patient knows that it's subject to change based on how their teeth are moving. Another office, the doctor reviews their monitoring 1 week prior to their scheduled appointment, and he will make schedule next appointment notes, or if the appointment needs to be rescheduled because the patient's not ready, then he communicates that back to his team. So instead of trying to look into the future 8, 10, 12 weeks and guess where the patient's going to be, he says, I'm not even going to waste that energy. I'm gonna wait 1 week before their appointment, see where they actually are, and make the treatment decisions that need to be made at that time. Another one, they schedule based on goals. So we'll talk a lot about what DM goals are later on in the webinar, but this doctor will use that and then adjust the scheduled appointment based on if the goals are reached prior. So a little bit of that dynamic rescheduling model as well. And then there's some that there's no appointment scheduled in the office and they're monitoring for archwire passivity. And when that alert comes through, that's when they're reaching out to the patient and appointing that patient at that time. So again, you're seeing a lot of different definitions, a lot of ways to deploy the term dynamic scheduling in your practice. So what do I think dynamic scheduling is? What's my definition? Well, in my mind, I'm trying to synchronize the delivery of care with the need for care. I want the patient to come into the practice when there's a need, when I need to repair a bracket, change a wire, add an attachment, give them more aligners, whatever the case is. I want the patient in the office only when they need to. I don't want them making unnecessary trips. Since we are in the suburbs, a lot of my patients have quite a drive to get to me. Mom may work in a different town, then the kid goes to school, and then my office is in a third town. And it's a half day process for the parent or guardian to check the kid out of school, bring him to the office, come to the appointment, then do it all in reverse to get back to work. And in my mind, they're just coming in for a 10-minute check appointment, but it's 4 hours of the patient's time. So I wanted to eliminate that situation as possible so that my patients can stay engaged in their lives, in school and sports, extracurricular activities. Parents and adult patients can stay engaged with the social events that they want to go to, work, whatever it is that they're involved in. Instead of forcing them to come into my life on my time, I want to be welcomed into theirs on their time. So going into their phones, doing the scan so I can see what's going on without pulling them out of their life. And then the last part of that definition is I want a customized treatment at the patient level. So we all try to do this the best we can, but ultimately a lot of orthodontics ends up being kind of like a cookbook recipe where we have our wire sequence and we have our intervals that we're accustomed to and comfortable with. And we just kind of put the patient through those paces. And then at the end of treatment, if we hit a home run, high five. If we don't, that's when we kind of reassess and tweak whatever needs to be tweaked for the patient. But I wanted to get to as complete a custom of treatment as possible for each patient. And we all know that some patients' teeth move faster than others, and some patients respond better to different modalities than others. So I wanted a way to track between each visit where my patient is, how their teeth are moving, and then customize those intervals to the unique patient that I was treating. So shifting into gears, what are the benefits of dynamic scheduling? What's the advantage? Well, for us as a doctor, we needed time. We did have a third doctor from 21 to 22, and it was great. The practice was growing. We brought in this young associate, and he was fantastic. Patients loved him. The practice, again, continued to grow. And ultimately, that doctor decided to move back out to the West Coast. He was a little homesick, and we were sad to see him go because he was and still is a fantastic orthodontist. But it left us with a vacuum of time to cover those patients that he was seeing. We hadn't grown yet to a full 3 doctor practice. We were pushing the 2.5 doctor size. Ultimately, when I crunched the numbers, I needed to find a day and a half a week of doctor time. So we worked 4 days, 4 full days, and I needed to find another day and a half. The easy solution would have been work Fridays and a half day Saturday. My wife and my dad's wife, who's also my mom, both those who are the true bosses of Designer Smiles, said absolutely not. You can't work any more days. So you have to find something else. And that's when we really started to dig into dental monitoring and see what it could leverage for us. We were a dental monitoring practice at that time, but we were still on a more traditional scheduling model because we didn't really have a need or a pressure point to push us into dynamic scheduling. We had more doctor than patient time on our schedule. But then with the loss of the associate, that flipped on its head. We had less doctor time than was required to see the patients that we had. And it really forced me to evaluate, okay, what does dynamic scheduling look like? At the time, I had heard of a lot of practices doing it, but those practices were almost entirely aligner practices, or at least upwards of 85, 90% share of chair aligners. That's not our practice. We are about a 70% bracket practice, 30% aligner share of chair. So very, very heavy on the bracket side. And I was like, how does this work? I can't just give all the arch wires to the patient and say, see you in 18 months after you use all these arch wires like you can aligners. So I had to kind of rethink how I schedule, how I treat, how long or how active my treatment modalities were in between visits. So again, losing the associate forced me to kind of reconcile all that information. And ultimately, I needed to merge that doctor and day and a half doctor time with an already full schedule. The spoiler alert, it worked. And I'm going to show you kind of how we did, how we phased it in, and the response from our patients. First, we're going to pivot to the staff because without them, it wouldn't be possible. They are instrumental in making any sort of change like this in your practice. So I encourage you to loop them into the conversation if you're thinking about this and get their input, see what they think. Ultimately, they appreciate how smooth the days are. We were already on dental monitoring, so we knew the condition of the patient's mouth when they were coming in, but now we're able to offload essentially a lot of our in-person visits onto a virtual clinic that is dental monitoring. And we're only bringing them in when they need to, not at a certain recall interval. So the days are running smoother. They get a full lunch hour, which everybody enjoys. And we're finishing on time. And I can honestly say that wouldn't be the case if we were still on a traditional scheduling model, trying to see that extra day and a half of patients inside of our work week that we were already working. So ultimately, this leads to a greater or more equal work-life balance. So they're not just absolutely drained at the end of the day. They have time to give back and energy to give back to their family and friends outside of the workplace. So we've talked a lot about the benefits for the doctor. We've talked about the benefits for the team. But does this work from a business standpoint? Is it clinically efficient, effective? Can it scale? Or is this something that only works in new startups or small boutique practices? Well, we found in our practice that treatments are progressing without backsliding. So typically, at least in our hands, brackets and wires patients, we would work up in arch wires and we would go through our arch wire sequence. And then, they may have a broken bracket and we don't know about it. They don't feel it. The tooth shifts and we have to drop down an arch wire. And then we have to spend time building it back up. And there's this kind of ping pong that can occur during treatment where instead of working through your arch wires and stopping because you're at the end of treatment, you're burning through multiple arch wire sizes, multiple arch wires at each size, rather, as you're trying to get them to a finished point. So we're seeing less and less of that because we're alerted when a bracket is broken, when something goes wrong with the appliance that we've set up. We're alerted in real time whether the patient knows about it or feels it or not. And ultimately, we're using less wires. So from an overhead perspective and a business perspective, we're saving money there because we're not having to, again, burn multiple wire sizes for that patient. And should you choose, or are you striving for a true straight wire finish, this would tailor right into that treatment modality. My dad and I, we were trained very, very effectively to bend wire. The program that we graduated from put us through several boot camps in wire bending. So we're not afraid to bend a wire by any means. We joke that we can straighten teeth with a coat hanger if we had to, but do we want to? And that's a different question. And we love the way that our cases are starting to finish almost in a true straight wire fashion, because we're allowing the teeth to become passive, to be fully expressed by the wires that we're using, instead of bringing the patient back too soon, thinking we need to do a detail bend, putting that detail bend in, when in reality, if we would just been more patient, that tooth movement would have expressed with the wire that we had. And ultimately, this is bringing less appointments, less in-office appointments for our patients. So they're able to stay, again, in the lives and the stories and the events that they want to be a part of, instead of having to come in to my world to achieve the smile that they want. Our treatment times aren't necessarily changing. So a 2-year case is still taking us 2 years. We're not necessarily moving teeth faster, but we're just being more efficient. And we're seeing our appointments per case decrease. With our aligner cases, moving to this model, we're showing about a 4 to 5 appointment decrease with our aligner patients. Now, that's also granted, before we changed to this model, we were seeing aligner patients every 8 weeks. So we would give them 8 trays and we'd see them 8 weeks, because that's when we saw our bracket patients. So it made sense to us to do the same. With our bracket patients, we're seeing about a 3 to 4 appointment reduction over the course of treatment. And again, we haven't changed the brackets that we use. We haven't changed our arch wire sequence. We haven't changed the way that we're putting on braces. We've just simply allowing the NiTi wires to work and become passive. And when the patient's ready for their next visit, because their teeth have gone passive, we're bringing them in at that point. So what's this mean for the patient? Well, they have a better quality of life. They're not always missing school to come to the orthodontist. So they're staying in school, doing their homework, seeing what life has to hold for them. They're able to go to band practice and recitals and sports events. If they go out of town for a baseball tournament, it's no big deal. Their orthodontic journey still progresses, even though they're out of town for an event. They're also more engaged in treatment because they're seeing the results of their work, of the braces or aligners, on a weekly basis. So they're checking out the morph video that pops up where they can track their before and after. And even if they're not doing that, they're seeing their smile change week after week after week in the mirror when they do their scans. So there's more excitement about the changes that are happening, and that excitement just builds and builds and builds throughout treatment until ultimately it culminates when brackets or aligners are finished and they see their final smile for the first time without any appliances in place. And that's in turn driving patient-to-patient referrals. So mom's at the sports event, the baseball field, and she hears another mom talking about that they have to go to the orthodontist every month or every 2 months, and it just ruins her day, and that she has to take off work, and she didn't have any time off to take vacations after that because it's all spent taking their kid to the orthodontist. And then our parents are sharing like, hey, our doctor has this app that allows them to check in with our son or daughter on a weekly basis. And if everything's going great, we don't have to bring them in, and they handle everything remotely. And then if something does go wrong, they're there for us, and we bring our patient or our son or daughter in. And you can just see the excitement around it and the light bulbs starting to go off in the community that, hey, there's a different way to do orthodontics that isn't as big of an inconvenience in the family life as it was before. Which ultimately, again, that conversation out in the community is leading to more new patients in our practice. So how do we do it? How did we successfully implement dynamic scheduling? Well, there's a couple ways that you can do it. And one way is to jump straight into the deep end and pick a day, and everybody at that point doesn't get an appointment, and you're going to figure it out from there. That idea absolutely scared me to death. And again, we have a large practice. We have probably 15 to 1600 active patients just in brackets and wires at any given time. So the idea of just over a month or so turning all those patients loose on a dynamic schedule when I hadn't seen it modeled before, I had no idea if it would even work, just froze. I was like, no way, I can't do it. So in turn, I came up with a phased approach where I could dip my toe in the water, get into the shallow end. Oh, the water's nice. Let's go into the deep end and kind of ease into this new scheduling model. So the first part is I had to make sure everybody was on monitoring, because if they weren't on monitoring, I had no way to track their progress. We all know that NiTi wires will work for an extended period of time, much longer than the 4 to 12-week intervals that you may be using at this time. We learned this in COVID, if you didn't know this already. We had patients that came back after COVID and been 6, 7 months that we hadn't seen them. They were in an 0-8 round NiTi wire, just cooking along for 7 months, unsupervised. And they come back into the office, and luckily I look and I'm like, wow, like this looks really good. Like you brushed your teeth, you took care of stuff. It was a risk that we took, or that the patient took, not coming in, but it worked out, and the wires worked and they did their job. And I was like, this is awesome. So how can we achieve these same kind of results, but in a more controlled, supervised fashion? So the first step is everybody's got to be on monitoring so that we can make sure that the appliances that we set up are doing what we want them to do. The second aspect, or the second phase that I went to, the shallow end, so to speak, was I started using goals. And with the goals with DM, I got to see the insights, which is the data behind it. And I started noticing that when I was bringing my patients back, their wires hadn't gone past it yet. There was still some activity left in them. So I'm like, hey, what happens if we start to maybe increase our intervals? Instead of seeing our patient every 8 weeks, let's go 10 weeks, or let's go 12 weeks. What happens in the patient's mouth with that extended time? And now I had a way to track it, so I could see through the goals. If I reappointed them in 12 weeks, if they went passive at 10 weeks, I would know about it and then able to bring them in. On the insight side, so the other side of that coin, the data side, I could actually map out and see how long my arch wires are being passive or being active for, and change my intervals to fit kind of the averages that I was seeing in the data. So that's where I kind of went with phase 2. Is like, okay, 8 weeks is too soon. The NiTi wires are still working. when I looked at the data, I had a big spike in passivity around the 12-week mark. So I kind of started, you know, moving my patients to a 12-week interval, bracket and wires wise. So instead of seeing them after 8 weeks, I started seeing them in 12, just again, monitoring the data, monitoring the goals, and then using that dynamic reschedule model that we talked about if I needed to move the appointment based on what I was seeing. When that was working, I'm like, okay, I'm feeling comfortable. It's working. What does the deep end of this pool look like? So we moved into the deep end and no next appointment. We put the wire in, tie it, secure it, send them out the door and say, hey, we'll call you, don't call us. Not really, but they're not leaving with an appointment. We're monitoring them each week on dental monitoring. Of course, if there's a problem that we see or that they call in and report, we're bringing them in and seeing what's going on. But for the vast majority of our patients, they love it and they understand the idea behind it. They also appreciate the less soreness that they have during treatment from the wire tightening. A lot of my parents will recall when they were in treatment 30 years ago, and they're like, oh, I used to hate when I would come get my braces tightened and I couldn't eat for a week afterwards. So when I tell them, it's like, well, now we're doing things differently. You know, I'm waiting for your son or daughter's teeth to finish moving and then changing the wire. And that's really cutting down on the discomfort that they feel at those wire change appointments. And you can just see like the relief come across their face. We're like, oh my gosh, that was one of the worst things I hated about braces. And I would hate for my son or daughter, who I love dearly, to go through that. So I'm just so relieved that there's a different way, that things have improved or changed since they went through treatment. So again, no next appointment. We're monitoring them. And then when their teeth are ready, that's when we're reaching out and bringing them back for another appointment. So let's dive in and go through the details of each of those phases. So remember, phase one is we have to get everybody on monitoring. We have to have a way of tracking our patients when they're not in the office so that we can monitor their treatment and make sure that nothing detrimental is happening. So how? Well, I would recommend that you pick the day, and every new patient from that point on jumps on monitoring. And then after that day, again, all new patients are going on monitoring from the get-go. Look at your active patients, and I would recommend any patient that has more than 6 months remaining in treatment, that we're delivering dental monitoring to those patients as well. So depending on what your recall is, if it's 4 weeks, then you would have a cycle of patients through your office, and then over a month, you have everybody on monitoring. If it's 6 weeks, 8 weeks, or 10 weeks, then of course it would be that interval before you catch all the active patients. But again, this way it doesn't overwhelm the team, it doesn't overwhelm you, and it doesn't overwhelm the patient, because ultimately we need not only the team to buy in, but we need the patient to buy in. They have to take the 30 to 60 seconds out of their day to send the scan to us. So if they don't realize the benefit and we haven't properly communicated how it's better for them and what's in it for them, then they're less likely to do it. So this method kind of gives us the time needed with each patient to, you know, get them on board as well. Again, we're phasing our rollout over whatever your recall is to catch all the patients, active patients, and the new patients that, again, have more than 6 months of treatment remaining. So with phase two, so we've gone through that appointment interval. We're seeing the benefits of it. All our patients are monitoring. Now we need to start figuring out what exactly is going on with our treatment. And different orthodontists treat differently. They use different auxiliaries, different mechanics. So there's no one answer that I can say, hey, if everybody does this interval, it's the best, because it depends on what treatment modalities you choose. And what works in my hands and in my practice with my patients may be different than works for you in your area and with your patients. So uh, this is where the goals and DM insights really come into handy, because you figure out exactly what your mechanics do, what your treatment modalities do, and what your auxiliaries do. So we want to eliminate, we want to utilize the insights side of dental monitoring and the goals to start collecting that data and figuring out how active our mechanics are and how long they are active. I want to eliminate all rubber band checks. Again, those are tough appointments. They bog down your schedule, at least they did in mine. And ultimately, it's kind of a lose-lose situation. If the patient comes in and they're not wearing their rubber bands, then you got to yell at them, and that's not fun. But if they came in and they are wearing their rubber bands, they just need to keep doing it, then it's like, wow, high five, you did your job. You need to keep doing your job, but I didn't really need to see you today because the work isn't finished. So now kind of everybody's wasted their time with that appointment because it was going well. So I want to eliminate those, track them on dental monitoring using the goals. So I'm alerted when we have that AP correction or that transverse correction, depending on what the rubber bands are that you're deploying at the time. And then I reach out to the patient and say, hey, great job using your rubber bands. Your bite's fixed. Let's bring you in and move you to the next phase of treatment. The same applies to retainer checks. Again, the best thing that can happen in a retainer check appointment is the patient wore their retainer and everybody wasted their time because they didn't need to come in for anything. So again, is there a better way to monitor retention? And the answer is yes. With dental monitoring, we're able to monitor for relapse, monitor for fit issues with retainers, bonded wires, lingual retainers, things like that. We can keep an eye on as well. So as long as they're doing their scan, there's really no reason for a retainer check. And we're only bringing in a patient that's in retention when there's a problem, when there's a fit issue, or their teeth have shifted. Going back into the active treatment world, there's no retie checks. We use self-ligation brackets, so we don't necessarily have the O-ties and rubber elastics that can decay with time. So there's no need for a retie check. We let the wire work, and if there's a broken bracket, if a broken arch wire, broken auxiliary, anything like that that happens, we're alerted through dental monitoring. So there's no reason to bring a patient in for a check just to see how things are, or to make sure that our braces are doing what they're supposed to do. And then on the aligner side, we did shift away from giving 8 aligners and seeing the patient back in 8 weeks to no aligner checks. We give all the aligners to the patient, and we use dental monitoring to track their progress through the aligners. Of course, we're bringing them back into the office if there's a mid-treatment attachment that needs to be added, or an attachment came off and needs to be replaced, or of course, if there's any IPR that's needed for the case. We're bringing the patient back when they're at the point where that needs to be done. Another cool feature of dental monitoring is they have a feature called adaptive scan frequency. So if the patient is really motivated and really wearing their aligners like we ask, their teeth are going to move faster than someone who's only wearing them 12 hours a day or 14 hours a day. But before dental monitoring, I didn't have a way to necessarily differentiate those patients unless they told me. And very few patients were honest and said, hey, yeah, I'm only wearing it about half the time. If you ask most of my patients, they're like, oh, yes, doc, I'm wearing it all day and all night. And, I'm even skipping a meal because I don't want to take them out. Well, now I can actually see what they're doing on a week-to-week basis. And with adaptive scan frequency, the interval that they change will actually adjust up or back, meaning they may change at 6 days or 5 days or even 4 days, or it'll increase. So it may be 8, 9, 10, 14 days, depending on how they're doing. And it's all automated. So I set the parameters as the treating doctor, and I set the floor and the ceiling, and then allow their performance with the aligners to dictate what their interval is. So it's, again, it's customizing treatment to how the patient is using the appliance. So when I give them the trays, I have no idea if they're going to change every 7 days, every 5 days, or every 14 days. And that also can change. It may be 7 days for a week, or excuse me, for a month. And then they may go on vacation for 2 weeks to Europe and they don't wear their trays at all. And we have fit issues, or they start to slack off a little bit. So the trays are still fitting, but they just need more time. And they slip to 8 or 9 day changes. And then they come back and they get back on the horse, and it goes back to 7 days and then down to 5. So there's just no way in my mind to kind of calculate, okay, if I give you 20 trays, I need to see you in 20 weeks, because it could be sooner or it could be later. So again, letting dental monitoring track their progress and alert me at each step of the way. Then I'm bringing them back when they need to, when they've finished the round, when they've gotten to a point where I need to intervene in their care once more. So that's the goals and the insights. Again, that there's a whole lot to unpack in that section. And at the end, we can answer some questions and dive in further to specific situations, but just know that that's a very, very, very powerful tool and a very robust tool that you can deploy in your practice. So the final phase, again, next appointment not scheduled. We are turning them loose and only bringing them back when they need to. So again, we're giving all the aligners, and we're not setting up an appointment. We have the protocols set up on dental monitoring to alert us at certain milestones, and of course at the end of a treatment round. And then we're appointing the patient at that time. On the bracket side, we're using passivity monitoring to, again, track how fast or how slow a patient's teeth are moving. So it may be, 6-7 weeks and they're coming back for the next arch wire change because there wasn't that much movement that was needed, or their teeth move fast. We've actually had patients that, we put the braces on, they're super crowded, we're able to engage most or all the teeth, and it takes 6 or 7 months for that first wire to go passive. And again, they're getting this resolution of their crowding throughout that entire process. Whereas I would have brought them back at 8 months, or excuse me, at 8 weeks to change to the next wire size, they would have an incredible amount of discomfort and soreness because, again, their teeth weren't ready for that extra pressure. This also leads to, in my mind, a healthier way to move teeth. We all learned about periodontal ligament spaces and blood supply and bone remodeling and how teeth move through bone. With this scheduling model, we're really protecting the vasculature and the blood supply to the periodontal ligament, which ultimately leads to a healthier biology and really tooth movement in general. It also is less discomfort for the patient. So we're protecting that periodontal ligament space, that blood supply, that nutrient supply to the teeth and the PDL, so that teeth move smoother, bone remodels in a healthier way, which ultimately results in less discomfort for the patient. So we talked about a lot. I've kind of gone through my story a little bit. I wanted to create a workflow for you guys that really compares some of the differences as you're stepping into dental monitoring and then starting to leverage more and more of the tools that are available within dental monitoring, ultimately culminating in a dynamic schedule without any appointments being made in the office. So before DM, the traditional model, we have braces. We have that, best day, putting braces on. And then depending on what your mechanics were and what your interval was, you booked an appointment for every 4, 6, 8 weeks. Some may have been longer than that. but you had emergency visits in between. And sometimes you would change the appointment, but a lot of times we would just slide the emergency visit in and say, all right, I'll see you in 2 or 3 more weeks when you're for your regular appointment. But we're only seeing these emergency appointments if the patient calls, if the patient alerts us, because we have no idea what goes on with the patient once they leave our doors, once they leave our practice. So we are relying on them to notice something that's different or that changed, and they're calling us, and that's when they're coming in for the emergency visit. We rinse and repeat and ultimately debond at the end of treatment. With aligners, again, we're adding the attachments at the beginning, delivering trays, but we only deliver enough to get us through to the next recall interval. I mentioned, we gave 8 trays at a time, and we saw them back in 8 weeks because that's when we saw our bracket patients, and that's what made sense to us at the time. We're checking the fit visually every time they come in, and we're making the decision. Okay, is that a good fit? Is it maybe not quite a perfect fit, but still good enough? Or, yeah, that tooth isn't tracking. I need to do a mid-course correction. But again, we're visually making that determination. And then based on that decision, we're giving more aligners and appointing them, or doing a mid-course correction and bringing them down that pathway. Again, rinse and repeat until they're finished with their aligner treatment. So this is kind of how my practice ran before dental monitoring. This was kind of in my mind what the traditional model of orthodontics looked like. But then we added dental monitoring. So we didn't necessarily change the way that we scheduled patients. We just added dental monitoring on top of how we were treating patients already. So with braces, we're putting them on. We're still seeing them at the 4, 6, or 8 weeks that we were seeing them before. The difference here is emergency visits are happening when DM alerts us, not if the patient alerts us. So we're knowing a lot more about what's going on in our patients' mouths when they're outside of our 4 walls. And we're able to intervene at a better time, or rather sooner, before detrimental side effects happen, to get them back on track and keep treatment progressing. And then, of course, rinse and repeat until debond. With aligners, again, we're adding our attachments, delivering the 4, 6, or 8 aligners that you would have before. But again, instead of visually checking the fit of the aligner every 4th, 6th, or 8th aligner, I get a computer algorithm, a AI, to evaluate the fit of each aligner at each week. And then I also get the pictures myself where I can visually evaluate the fit each week if I need to. So there's a lot more going into the accuracy of the fit of each aligner. And then I'm able to, again, titrate how quickly the patient's moving through based on the fit of the aligner. So some aligners, it's not necessarily a big enough discrepancy to cause a mid-course correction. It just needs a little bit more time, a few extra days, an extra week, and then the patient's back on track. But before dental monitoring, I had no way of knowing that that happened because I only spot checked every 8th aligner. So when I saw this, and again, we start to, excuse me, let me back up. So we're relying on dental monitoring to check the fit. They're coming in still every 4th, 6th, or 8th tray, and we're evaluating, and then based on how they're doing, we're giving more trays or doing a mid-course correction. So as we were seeing this evolve, and we were starting to feel like there were some unnecessary appointments, like they were coming in on the aligner side. I'm like, yeah, it's looking great. Like, keep doing what you're doing. Here's more trays. I'm like, I probably could have given that patient more freedom, more trays to begin with, because they're doing well. So we started noticing things like that as we were, starting to implement and see the benefits of dental monitoring. So then we started to make changes to our schedule at that point. We started extending the appointment intervals. And what that looked like with braces is, of course, we would put the braces on, and then we started stretching the appointment intervals to 8, 10, 12, 14, 16 weeks, even beyond that. Again, we still had the same emergency visits in between when DM alerted us that there was a problem. So we're able to see what was going on. The kind of light bulb at this point started to go off, and that, you know, we knew that our appliances would work. We knew that night-tie wires would work longer than 8 weeks. I just didn't trust my patient to take care of the appliance. I didn't know what the patient was going to do to the wire, to the brackets, unsupervised for 16 weeks. But now with dental monitoring, I had a way of checking in every week to ensure that everything was in tip-top shape, working order, and good to go. So again, rinse and repeat with those longer intervals all the way to debond. So again, we're starting to get more custom, but again, everybody was pretty much the same, 12 weeks, 12 weeks, 12 weeks, all the way through. With aligners, we were adding the attachments at the beginning. We started to give more and more aligners to the patients to see, okay, how are we doing? Do I need to check you every fourth? No, let's do every eighth, or go from 8th to 12th aligner and kind of see how it goes. Again, using DM to check the fit for those visits that were not in person. We also started to leverage the adaptive aligner change, that change frequency that I talked about. So again, we gave them 12 aligners, but if they did a really good job, that may not necessarily take 12 weeks for them to get through. The vice versa is also true, in that if they didn't do so hot wearing them, it may take longer than 12 weeks for them to get through that aligner set. Again, I had patients coming back in that were supposed to be on aligner 12 that were on aligner 10 because they ran into some hiccups. I'm like, well, I don't really know kind of what's going on in that, where you are in treatment. It's like, I really want to see what these next 2 trays do before I make a treatment decision. So again, that's where the adaptive change came in, and the alerts from dental monitoring. So I knew exactly where a patient was in that tray sequence. And then of course, we're given more trays or progressing with a mid-course correction, depending on what's needed for the patient. So this is where I kind of sat for a long time with dental monitoring. And when we lost the associate, I'm like, hey, I need more. This isn't going to work with the patients that we have, the numbers wise, with only having 2 doctors. So with dynamic scheduling, we went to, again, bonding for braces, appointments only when the arch wires go passive. So it could be 6, could be 12, could be 20 weeks, could be 8 months, whatever's needed for the patient, again, fully customized to them at the patient level. We're still seeing the emergency visits and the debond at the end. With aligners, again, we're adding all the attachments. We're giving them all the trays. So not only does that help out with storage inside the office, it cuts down on the appointments that the patient's coming in on the backside. We're relying on dental monitoring to check the fit of each tray. We're using the adaptive aligner change. So again, there are phases of treatment where they will move faster, some will move slower, and it may change even within the same patient. So again, customizing that treatment to them. If you've been an aligner patient yourself, you have firsthand experience in that, different aligners are moving different teeth at different times, and patients will report back. They're like, yeah, I didn't have any soreness. And then with tray 10, this canine tooth, I could really feel that it was moving. So again, we get to that point. The canine tooth is a big tooth with a long root. It may take more than 5 or 6 days to move that one aligner's worth of movement. So again, DM's catching all that and programming that in so that as the patient's moving through treatment, they're increasing their change frequency when needed and decreasing it when they're able to. So an appointment is given to the patient only when they need to come in, when they're out of trays, or if we need to replace or add an attachment, or if we need to do a mid-course correction. But again, we know exactly what's going on with the patient. We make the appointment for exactly what is needed. bring the patient in, do our work, and then the patient's right back out the door. The cool part about the future here is with smart STL and dental monitoring, we wouldn't necessarily need to bring the patient in for a mid-course correction. We can see on the DM dashboard that, hey, a mid-course correction is needed. I need to reorder trays. Then at that point, dental monitoring can precipitate out a new STL file based on the patient's current tooth position. I upload that into my aligner manufacturer of choice, create new aligners and new treatment. And then when I have those aligners in-house ready to give the patient, that's when the patient's coming back into my practice for the first time. So again, we're streamlining this process, and the patient is only coming in when they need to. And then, of course, rinse and repeat till they're finished. So you can see over these 4 window panes how my practice has changed and how I've made incremental changes to not only how I treat, but the scheduling of those patients during treatment to kind of finally arrive at dynamic scheduling. Could you have gone from the first pane to the 4th pane of dynamic scheduling in one fell swoop? Absolutely. I just didn't feel comfortable doing that with my patients, and I much preferred the phased approach. And that's my evolution through dynamic scheduling. So in summary, again, phased approach is the one that I opted to. Big part of that was talking to my team, was getting them on board, allowing them to understand, okay, why are we making these decisions? That was particularly important in my practice with my dad, because I mentioned he started the practice in 1985. And he had made some material changes and bracket changes, but for the most part, from the team members' point of view, the practice had worked and done pretty much the same thing from 1985 to 2021, 2022. So it's like, why do we need to change now? Like, what we've been doing is working. So getting the team on board and kind of allowing them to understand, okay, this is the technology, this is why we're making those changes, this is the benefit for the patient, so that they're bought in and they understand exactly why those changes are occurring. And then again, using the goals, we have to have a way of tracking our patients. We can't just turn them loose and hope for the best. So using DM goals to really track the progress, and that way we're alerted as to when they're ready for their next appointment. Whether that's with R2R passivity or again, using that adaptive scan frequency for aligner patients. Thank you guys so much for your attention today. This is some festive holiday photos. We actually do a charity fundraiser we call Santa Paws, and we bring in Santa Claus himself with all of the furry friends of our community. So they get to have their furry friend take a picture with Santa, and in exchange, we ask for a donation, dog food, cat food, toys, things like that to donate to our local animal shelter. So it was kind of a fun event that we just had last week here. And again, I wish you guys a Merry Christmas, and definitely want to be a resource for you guys. Here's my email address. Feel free to shoot me an email if any questions come up, any problems as you're making these changes with dynamic scheduling. I'd love to help out the best I can. Here is that survey link that Tracy mentioned at the beginning. So there's a QR code that you can snap a picture of with your phone, which will redirect you to the survey. I want to hear back from you. I want to see, did this resonate with you? What material would you like to see future webinars on, and so forth. With that, I'll turn it back over to Tracy. I think we got a Q&A portion, so don't be shy and ask away.
We do, Dr. Berry. Hang on just a second. Dr. Seth Briggs writes, great presentation. Thank you for this. How do you create time in your template to get the patients in on demand with 1 to 2 weeks as needed? And then there's a second part. I'll go ahead and read it. And then if you need to answer it in 2 parts, that's fine.
Sure.
How do you prevent the columns from filling up and eliminating options for short notice on demand appointments?
Great question. And honestly, jumping in from the sideline into the deep end is probably the best way to handle that question, because then your whole schedule goes from traditional to dynamic in one fell swoop and you have the room. Ultimately, like we had talked about, I did the phased approach. So I didn't have that luxury. And what I did is I pared down some of my template that I was regularly scheduling on, but then opened up those columns as essentially an on-demand appointment. And the scheduling staff knew that, hey, I don't use these unless I'm scheduling a patient, that was on dynamic scheduling or that was needed to be an on-demand appointment. So as we're, phasing in and phasing out, moving through that process, the columns changed. And now that everybody's on a dynamic schedule, we're back to a more traditional looking template. It's just that we're not booking those appointments until they're needed.
So essentially they're just open, and then, 1 to 2 weeks prior they start to fill.
Exactly.
Okay. Another question, when building your template for dynamic scheduling, what did you do?
So we found that, oh, let me back up. So our template before DIM monitoring was very confusing. It made sense in my mind and my dad's mind, but having to train somebody on it, we realized that unless you're an orthodontist, it really doesn't make any sense. And through repetition, they got it, but it was a tough training template to learn on. And that's because we had 10-minute appointments, we had 20-minute appointments, we had 30-minute appointments, we had 40-minute appointments, we had 60-minute appointments. And just, I mean, it was like a retail company that had 1,000 different SKUs and items to track and inventory. It was crazy, but it's the best that we could come up with. What we started to find with dynamic scheduling is we didn't need the 10-minute appointments anymore. We didn't really even need the 20-minute appointments anymore. So we consolidated our template down into just 30-minute appointments and hour appointments, depending on what we were doing. Obviously taking braces off and putting braces on would be those longer appointments. But everything else is pretty much a 30-minute appointment, because we know that when the patient comes in, there's work to be done. They need to be there, and we want to have the time set aside to take care of their needs when they're here. So our template is a lot simpler now as a result of dynamic scheduling.
Right, right. Okay, so I have a couple more questions. I know we're running close on time, and if you guys need to go ahead and jump off, you most certainly can. But I think these two questions are very important. Um, One of the questions is, did repo appointments become less in being scheduled?
We still have, the bond failure appointments that we have to repair. As far as repo appointments, we're still doing them around the same time. So we tend to do a lot of our repos when we get into rectangular NiTi wires. And we'll make the note that that's what we want to do next time. Says, hey, we're putting in the first rectangular NiTi wire in our sequence. And hey, when this wire go passive, we want to book them for a repo appointment so that we can evaluate bracket position and make changes that we need to. So that necessarily didn't really change with dynamic scheduling, because we're still doing the next appointment note that way. And it's just when the scheduling staff looks at the alert and says, okay, this patient needs to be scheduled, and oh, we're doing a repo appointment. So they'll schedule them for that when they reach out for that on-demand appointment.
Okay. This question is a couple of different parts. It is a big one. What do you use for bite opening, such as turbos, upper six band lock, for excessive overjet? And then, do you see that DM reliably catches tooth to appliance contact? And then there's a third part. Do you see that this is a common need to come in earlier than the passive wire would dictate?
Great series of questions. So we use uh, the it's called blue goo from Ormco. It's actually what they recommend to bond ceramic brackets with. We have it on hand and we use that for our bite opening composite. And it's an etch and adhesive or primer process as well. We typically add it to either the lower sixes or the upper fours. Every now and then, depending on reverse overjet and things, we'll do a traditional bite turbo on the incisors. But for the most part, we try to stick it to the premolars or molars, depending on our treatment goals. And I don't necessarily have a foundational or data backed question or answer for does DM reliably catch tooth to appliance contact, because we tend to do a good job with our training and with our checkout procedure where we're seeing there's plenty of clearance between the bite and the appliance. But I assume the AI is smart enough to detect that reliably, but I will say that if it's not, you'll definitely catch it when the bracket comes loose. I know that's not necessarily the answer you wanted to hear, but your patient will be taken care of no matter what in those situations. But again, we're taking the extra step and the extra effort when the patient's in the chair that first time to make sure that there's no bite to appliance interaction. Of course, if we are alerted to that because teeth move during the process, then we're bringing the patient in and adding to those or subtracting from the bite opening composites.
Okay, let's do one more question. How do you use dynamic scheduling for phase 1 patients?
That's a great question. And the phase 1 patients, they're not a huge percent of our practice. And it is tough because, phase 1s are typically, 12 months of treatment, 14 months of treatment. So do you really want to spend 8 months of your 12 in the first wire? So there is a little bit of nuance with phase 1 patients. We are typically with phase 1 less focused on straightening teeth. Of course, we want to get the teeth straight, but we're more concerned with spacing and creating the adequate arch length for the future permanent teeth to come in. So with dynamic scheduling, it's more tracking. We use open cool and NiTi open cool springs to open our space, and it's more tracking the progress of those. So again, if there's still punch in the spring, we don't necessarily need to bring the patient in for that just to put a new spring in. But we also want to be alerted if there's no punch left and, we don't want them to sit for an extended period of time when we're not actively opening up that space. So again, there is some nuance, but you can account for that in how you set up the protocol for your phase 1 versus your comprehensive patients.
All right. That is all I had. Thanks, everyone. Please don't forget to fill out the survey here. It takes all of about 4 seconds, and it just ensures that we're able to put together effective learning webinars for you guys. Thank you, Dr. Berry. Thank you,
Thank
everyone,
you.
for spending your time with us this afternoon. I hope everyone has a great afternoon.